Okay, I see the numbers still growing, but I think we're gonna kick things off. Good afternoon, everyone, and welcome to today's Pancreatic Cancer Focus Fireside Chat and our final Fireside Chat of the year. I'm Amna Hussein. I'm the Community Outreach and Engagement Manager at the Masonic Cancer Center at the University of Minnesota, your host and moderator for the monthly Fireside Chats. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Our office serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our small but mighty team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Each month, we host these virtual fireside chats to share knowledge, raise awareness, and highlight the people and the research driving change across the cancer continuum. Today's conversation is an important one. We're talking all things pancreatic cancer. Pancreatic cancer is a disease that is often difficult to detect early and continues to pose major challenges. By creating this space, we're able to learn together, hear from an expert, and ask questions that will help us bring much needed awareness to a disease that too often goes unseen until it's advanced. And I'm so grateful for all of you for taking the time to join us today. So it is now my pleasure to introduce today's speaker, Dr. Guru Trikudanathan. I know I probably butchered that, so I'll have him repeat his name. But Dr. Guru is truly the pancreatic disease expert here at the University of Minnesota. He wears many hats in the world of digestive health and pancreatic care, and we're so fortunate to have somebody of his expertise with us today. Dr. Guru is a gastroenterologist, a professor of medicine, and is the director of advanced endoscopy and medical pancreatology in the Division of Gastroenterology, Hepatology, and Nutrition at the University of Minnesota, just to name a few of his roles. Dr. Guru is widely known for his work in complex pancreatic diseases and advanced endoscopy procedures, and his research and work has shaped how clinicians across the country and around the world approach pancreatitis. He has over 160 peer-reviewed publications, majority as the principal author in several high-impact journals. He was the recipient of the American Pancreas Association Young Investigator Award in 2020 and has been recognized as a top doctor by the Minnesota Monthly Magazine and Minneapolis St. Paul Magazine for several years. He also has received numerous awards for his leadership, research, and clinical excellence. And so we are incredibly grateful and fortunate to have him with us today to shed light on pancreatic cancer. But before I pass things over to Dr. Guru, I'll cover just a few quick housekeeping items. Today's fireside chat will be recorded as they always are and will be posted on the Masonic Cancer's YouTube page by the end of next week. Closed captioning is available for this session, so you can turn it on by clicking the CC button at the bottom of your Zoom screen. For University of Minnesota employees and spouses participating in the university's Employee Wellbeing Program, you can claim your 200 well-being points for attending today's fireside chat by completing the form that will be dropped in the chat. Throughout Dr. Guru's talk, we invite you to engage, so please use the Q&A feature to submit any questions or comments that you have. We have some time carved out at the end to take some questions. All right, without any further ado, I'm going to pass the floor over to Dr. Guru.
Thank you, Amina. I'm just going to start by sharing my slides. Are you able to see them?
Looks great.
All right. Thank you, Amina, once again for such warm introduction, and it's truly an honor to be a part of this pancreas cancer fireside chat. To all of you who do not know me, I am Dr. Guru Trikudanathan. I am a professor of medicine and the director of advanced endoscopy at the University of Minnesota. Um, and the following are my disclosures. I am funded through NIH and I have industry funding as well, but none of which is relevant to this presentation. So, first of all, why is this conversation important? Uh, I'm sure everyone is aware of this. November is the Pancreatic Cancer Awareness Month, and Amina therefore invited me to, to this fireside chat, mainly to focus on pancreatic cancer for lay people, for patients, for people who do not know anything about pancreas cancer. And why is this important? Because pancreatic cancer is consistently one of the most challenging cancer to detect and treat. And this is a recurrent theme. I'm going to keep bringing this up again and again. It is emerging as the second leading cause of cancer-related death. Most of the patients, unfortunately, present with rather advanced disease, and it typically presents late, lacks early symptoms, and it progresses so rapidly. And even when you diagnose, it's resistant to most of the standard therapies. So the prognosis has been dismal. And we, as a community, we do need to raise awareness, and that's the purpose of this talk, to raise awareness of the risk factors, warning signs, and support high risk surveillance and engage the community. The goal is early intervention so we could have much better outcomes. So, to start off, where is my pancreas? This is a question a lot of patients ask me. Patients know when you get a heart attack where the heart is, they know where the lungs are, they know where the brains are, but where brain is, but pancreas, not a lot of patients know where the pancreas is or what the pancreas does until it produces something, until you have cancer, until you have pancreatitis. That's when they realize, oh, there is this organ called pancreas. Um, so the pancreas is an organ which is located behind the stomach and the duodenum, and it's closer to your back. It's a retroperitoneal organ. As you can see, it's a leaf-shaped organ, and it's extremely vascular, and it's usually soft and easy, fragile and easy to tear. But when you develop pancreatic cancer, it hardens. Um, when patients ask me what does my pancreas do, I tell them there are two major functions of the pancreas. The one what we call as an exocrine function, where the pancreas is very, very important to in its role for producing enzymes. It produces the amylase, lipase, protease. These are the enzymes which digest fat, proteins, and also carbohydrates. And the second important role of pancreas is endocrine function. The pancreas produces really important hormones like insulin, glucagon, somatostatin. These are some of the hormones which regulate your blood sugar. So the pancreas does these two important functions, exocrine and endocrine functions. And when the pancreas, when you develop pancreatitis or pancreatic cancer, these functions get disrupted, and that's when the patients bring their symptoms to our attention. So moving on, a lot of us would have read this Pulitzer Award winning now a book called The Cancer is the Emperor of All Maladies. If cancer is the emperor of all maladies, then pancreatic cancer is the emperor of the emperors. Uh, why is it? That's what we are going to be talking about. And uh, when we talk about pancreatic cancer, there are different types of pancreatic cancer, but the most common, nearly 90% of the patients, when we call what we call pancreatic cancer, is pancreatic ductal adenocarcinoma. As you can see from this picture, the cancer arises from the ductal epithelium, and that's why it's known as a pancreatic ductal adenocarcinoma. This accounts for 90% of the cancer we see in the community. The second common cancer is what we call as a pancreatic neuroendocrine tumor. This is relatively slower growing tumor. One of the famous examples I have for patients is Steve Jobs had pancreatic neuroendocrine tumor, and we all know he survived for several years. And this tumor arises from the neuroendocrine cells, be it the insulin producing cells or glucagon producing cells. Some of these tumors can be functional, and when they are functional, they secrete hormones into the bloodstream, and those could produce symptoms as well. And these account for 99% of the cancers. There are some really, really rare cancers when you could get cancer of the lymph nodes surrounding the pancreas. That's the pancreatic lymphoma. You could get cancer of the connective tissues in the pancreatic cancer, which is known as pancreatic sarcoma. You have a variant of pancreatic cancer called acinar carcinoma, which is again very rare. And this is a tumor called solid pseudopapillary cancer. This is seen in relatively young patients. Again, all this is broadly termed as cancer. For today's talk, we are going to be talking about pancreatic ductal adenocarcinoma. That accounts for 90% of the cancer. So pancreatic cancer is always bad news. This is the a slide which shows the pancreatic cancer survival in relation to other cancers, and as you can see, the pancreatic cancer has the least survivable malignancy. And this is a slide which I see literally in every pancreas cancer talk in the oncology symposiums. Pancreatic cancer is emerging as the second most common cause for cancer related deaths. It's by 2030, it has already surpassed breast cancer. By 2030, it's definitely going to be the second most common cause, and it's growing. And at some point, it's going to be the most common cause for cancer related deaths. Um, why is that? Because majority of the patients, nearly 85% of the patients are inoperable on presentation. So this is the 2024 statistics. If you where they looked at 66,440 newly diagnosed pancreatic cancer. Half of them were metastatic on presentation, and other another nearly more than one third of them were unresectable. It was only 15% of the patient who had localized pancreatic cancer whom we could do curative resection. In other words, 85% of the patients were inoperable on presentation. And looking at the stats in a race-wise manner, there's not much of a difference, but African Americans have slightly less, slightly worse prognosis than whites. But if you again look at this stats here, nearly 50% of the pancreatic cancer, at least more in the African Americans, are metastatic at the time of presentation. And this is the 5 year survival. And if you look at the 5 year survival, when you have the cancer, when stage one or stage two, when it's localized, and if they are resected, the prognosis is good. At least 40 to 44% of the patients make it beyond 5 years. But as you see, once the cancer is metastatic, it's roughly 2% to 2 to 3% who make it beyond 5 years. And this is the overall uh, pancreas cancer survival. It's the 5 year overall survival is just 13%. The only good news is it has become better. It used to be 3% 2 decades ago, 4% last decade, and it's now 13%. And with better chemotherapy and better surgical options, I'm hoping that this number keeps getting better in future. So, why is pancreas cancer diagnosed late? The primary reason is most of the symptoms attributable to pancreatic cancer are very non-specific. Very few symptoms occur early in the illness, and this is why it's important to know the pancreas anatomy a little bit. Pancreatic cancer arising in the body and the tail, literally until it has spread to other parts of the body, you wouldn't notice any symptom. The only time a patient can have a symptom is from the pancreatic body or tail cancer is when the cancer invades deep into the retroperitoneal nerves and can cause pain. That's when you really know that you have a pancreatic body cancer or a tail cancer. Pancreatic head cancer, which is more common, fortunately could be diagnosed a little early. The reason being the pancreatic duct and the bile duct communicate and have a common channel. And when you have a cancer compressing this common bile duct, you could become jaundice. So that's usually one of the early signs of pancreas cancer. So the symptoms we typically notice are painless jaundice, dark passage of dark colored urine, or clay colored stools, and some itching. So these are some of the symptoms which a patient who has a pancreatic head cancer could present with. And again, it's painless jaundice, and there is significant weight loss. When I talk about weight loss, we are looking at like 10% of the body weight. But when you have painless jaundice and you're beginning to notice some weight loss, that's when you need to you need to know that this is an alarming symptom, and you need to draw attention to your providers. Uh, Pancreatic cancer can also cause loss of appetite and significant weight loss, as we discussed. It could also cause fatigue. Some patients could become depressed because the pancreatic cancer produces substances which make them depressed. And new onset diabetes is one of the early signs of pancreatic cancer. So if all of a sudden, if you become diabetic and you're losing 10% of your body weight, that's when, if you're 60 and above, that's when you'll have to start thinking of cancer, particularly pancreas cancer. So the risk factors, some of them are modifiable, some of them are non-modifiable. So as you grow older, the risk of pancreas cancer increases. So 60 and above are patients develop the risk of pancreatic cancer increases after you're 60 or more. Pancreas cancer, there are certain genes which are responsible for pancreas cancer, and we'll touch down a little bit about those genes. And if you have family history of pancreas cancer, you are definitely at more risk for pancreas cancer. But the modifiable risk factors are the things which we need to focus on. Cigarette smoking or tobacco consumption is one of the most common cause for pancreas cancer. And of late, we realized that obesity, particularly visceral obesity, can also cause pancreas cancer. And high fat, low fiber, processed food diet, those are all risk factors, as well as risk exposure to toxic chemicals and industrial chemicals. So these are all some of the known risk factors for pancreas cancer, but there are a lot of risk factors we do not know about. So how do we diagnose pancreas cancer? The CT and the MRI are the leading diagnostic modalities for pancreatic cancer. Both are equally good, but the cancer guidelines recommend a triphasic CT, or in other words, a contrast enhanced CT, as per a pancreas protocol, as the best diagnostic modality to diagnose pancreas cancer. As you can see in this CAT scan, based on the contrast, you would also be able to assess the vascular involvement as well. The MRI is a little bit more expensive and not readily available, but MRI is equally good as well. So once a patient is known to have a pancreatic mass, they refer to the gastroenterologist. That's where I come into play. They refer the patients to establish a diagnosis, and for that, you need an endoscopic ultrasound. Endoscopic ultrasound is a procedure which we do with sedation, where we advance a scope which is fitted with an ultrasound through your mouth, throat, food pipe, stomach, duodenum. Behind the stomach and the duodenum, you will be able to visualize the pancreas, and you could see tumors like this. And you could also assess the vascular involvement. You could assess the staging as well, to an extent, as far as whether it is spread to the liver or the peritoneum. But most importantly, we'll be able to sample, and this is what is important to establish a pancreas cancer diagnosis. The sampling is called a fine needle aspiration or fine needle aspiration biopsy. We do it under real-time endosonographic vision, and typically we sample the mass, and we have a cytopathologist in the room, and they will tell us if the tissue is adequate, and sometimes if the tissue is diagnostic of cancer, they will let us know. So this is where I come into play. And once the cancer is diagnosed, we make the other referrals. Sometimes the other modalities, these are modalities which are practiced at increasingly at the University of Minnesota. They are more at Mayo Clinic, is like staging laparoscopy. During this, they could do a laparoscopic assessment to get peritoneal washing. They could also laparoscopically visualize spread of the cancer, and that overall yield is about 21%. We are increasingly using this, but this is used at Mayo Clinic more often. As far as the tumor markers are concerned, other cancers like ovarian cancers have really good tumor markers, but pancreas cancer, the tumor marker, the only one we have currently, which is well established, is the CA 19-9. And CA 19-9 elevation is associated with worse prognosis. But we do need to remember several caveats. Nearly 8 to 10% of the patients, they lack Lewy antigen, so they are non-secretors. So in other words, 8 to 10% of the pancreatic cancer patients could have pancreatic cancer, but they may not be producing the CA 19-9, and they may have falsely negative, so that's why it's not reliable. And nearly one third could have nearly normal levels. And CA 19-9 is a non-specific marker. It could be elevated in jaundiced patients and patients with benign conditions as well. So just by having a mildly elevated CA 19-9, one should not freak out and think that they have pancreas cancer. So now that we have established a histological diagnosis of pancreatic cancer, the question comes as to what next. And this is where the gastroenterologist, we pass it on to our surgical oncologists and medical oncology colleagues. But before we do that, they want us to do something called staging. And by staging, we are trying to assess how big the cancer is, whether the cancer is pressing some vital vasculature, arteries, or veins, whether it has spread to other parts of the body. And when it's spread to like the organs like liver or peritoneum, that's when it's called metastatic pancreatic cancer. And why do we need to do staging? It helps us assess the outlook or the prognosis of the cancer. It helps the oncologist decide which treatments are the best. And you could also plan whether you could also make decision as to whether you need chemotherapy, radiation, or surgery, or go for surgery. These are all some important decisions we could do after staging. And again, there are several different types of staging. This is the most widely accepted classification, or the American Journal of AJCC classification. And you have stage 1 and stage 2, known as the localized pancreas cancer. Again, stage 1 is subdivided into stage 1A when the cancer is the size of a cherry, less than 2 centimeter, or the cancer could be stage 1B, where it's more than 4 centimeter. Stage 2A is when the cancer is more than 2 centimeter and it's not involving a lymph node. And stage 2B is when it's involving adjacent neighboring lymph nodes. So these are the definitions for localized pancreatic cancer. But typically, we encounter locally advanced pancreatic ductal adenocarcinoma. This is when the cancer has started invading some vessels. There are, as I said, the pancreas is a very vascular organ, and it's notorious to invade some arteries and veins nearby. Um, and stage 4, and as we briefly talked about, is metastatic pancreatic cancer, when the cancer has spread hematogenously to the liver or to the peritoneum. It's spreading to the lungs is quite rare, but roughly 7% of the patients could have cancer spreading to the lungs. It could spread to lymph nodes. So the cancer spread is both through hematogenous and through lymphatics, and it could also spread to the bones. And switching gears, we do need to talk about management of pancreatic cancer. It comes under two broad categories. You could either have curative management or non-curative or palliative, and it all is based on what stage of pancreas cancer you are at. But also we need to remember the any successful pancreas cancer treat requires a multidisciplinary tumor management, and this is where the Masonic Cancer Center really excels. You could get surgery, you could get chemotherapy everywhere, but when it comes to other things, like how do you manage your anxiety, how do you manage the pain associated with pancreas cancer, how do you have any recommendations for malnutrition, and also patients have various family support issues. The Masonic Cancer does a phenomenal job getting all the experts under one building, and the advanced endoscopists, including me, we are in charge of, we take care of draining the bile duct, opening up the duodenum if the need arises. But this is where coming to University of Minnesota and taking advantage of the Masonic Cancer Center is really, really helpful, because we provide the whole package, the whole multidisciplinary tumor management. The management strategy changes a little bit with the center, but 99% this is typically the management strategy. As we said, the stage one are usually resectable, but majority, 85 to 90%, come under the borderline resectable or the unresectable the time of presentation. And typically, we start off with neoadjuvant chemotherapy at University of Minnesota. We typically do neoadjuvant chemotherapy. At other centers, radiation is also used. And then, if the cancer is metastatic or definitely unresectable, then we just do the chemotherapy, and it's more with a palliative intent. So the neoadjuvant chemotherapy, the two most popular regimen are the gemcitabine paclitaxel regimen or the FOLFIRINOX regimen. And typically, as soon as a cancer is diagnosed, the patient gets a line placed. And they will have baseline CA 19-9 levels. The circulating DNA, these are more experimental. This is not mainstream yet, but it could be done. Get the triphasic CAT scan we talked about. We don't typically do PET scans, but PET scans can be done as well. And get the baseline CA 19-9. Sometimes staging laparoscopy also helps when there is a question. We start the patient on these chemotherapy regimens. It could be most of them are IV infusion based. There are some oral chemotherapies as well. And then typically the oncologist will do some sort of a restaging. They will get CAT scans, the CA 19-9 again. And at this point, if the patient is tolerating and responding, in other words, the CA 19-9 from the baseline is significantly going down, the cancer is not spread based on the cross-sectional imaging, then we recommend continuing the first line. But some of the patients could develop side effects from the chemotherapy, and when they do that, they would change the chemotherapy or consider other things like radiation at that point. So if a patient makes it through the chemotherapy and is still resectable, that's when we subject the patients to resection. And resection is based on the site of the pancreas cancer. If you have a pancreatic head adenocarcinoma, the resection we recommend is called as a Whipple procedure. And this involves removing the cancer, and they do frozen sections in the operating room. So they remove the cancer, the pancreatic head, along with 2 or 3 centimeters of healthy pancreas, using the frozen section, frozen specimen evaluation. And then they start reconnecting. They reconnect the body and the tail of the pancreas to the small bowel, called as a pancreatic jejunostomy. And then they connect the small bowel, the loop, they bring it up, and they do what we call as a hepaticojejunostomy. And they also connect the stomach to the small bowel. So there are three important anastomoses: gastrojejunostomy, hepaticojejunostomy, and pancreaticojejunostomy. By no means this is a minor procedure. This is a major procedure. Uh, our surgeons, we have three really good surgical oncologists at University of Minnesota. They are all really experienced. And this is where, if you need a surgery like this, a large volume center really makes the difference. Typically, the surgery duration is about 4 to 5 hours, and patients typically need a week of hospital stay. If everything goes well, they get discharged in 7 to 10 days. Again, that's the typical patient, but some of them could recover faster. Some of them may need a longer duration of hospital stay. If the cancer arises in the body of the pancreas or the tail of the pancreas, then we recommend something called the distal pancreatectomy. These are not as morbid as the Whipple procedure. It involves removing the spleen because the spleen is usually plastered around the pancreas. So, and after whether it's a Whipple or a distal pancreatectomy, the surgical oncologist also removes some lymph nodes. And if those nodes are positive, then patients get what we call as adjuvant chemotherapy or sometimes adjuvant radiation. This is to destroy any further residual cancer cells, and this will prevent recurrence. This will prevent spread to other parts in future. So post-op recovery, again, it depends on every patient. Typical side effect or typical things to expect after a Whipple are, your stomach is removed, and you could get delayed. A portion of your stomach is removed, so you could have some delayed gastric emptying. You could have some nausea, vomiting. You could feel bloated or feel rather quickly, and nutrition gets impacted because you don't feel like yourself. It's a major surgery. Sometimes the immediate perioperative complications to watch out for are infection. Fortunately, at the University of Minnesota, the infection rates are low, but infection, we do give patients antibiotics. Because of pure nutrition, weight loss is also not uncommon. But the things we typically pay attention to are the patients developing some sort of an anastomotic leak. Remember, there are three major anastomosis we are doing. So we want to make sure there is no leak, and we will we usually monitor the drain output, and we want to make sure they don't have any fistula in before discharging. So if everything goes well, great. If they need chemotherapy or radiation as an adjuvant manner, great. But sometimes the cancer could recur. This is because of the micromets, which are super resistant to whatever we do. And this is not uncommon, even if the surgery goes very well, the chemotherapy goes very well. There are times when the cancer could recur within the first year, first 3 years. It's not uncommon. So why is that happening? That's because pancreatic cancer, that's a tumor microenvironment or the stroma. It's really tough, and it impairs chemotherapy. And as far as the chemotherapy is concerned, pancreas cancer is not that sensitive to chemotherapy, and you don't have a single targeted agent like you have for malignant melanoma, for example. You don't have a single agent. The CA19-9 is the only predictive biomarker we have, and it's not. And we talked about the pros and cons of CA19-9. So as far as adequately tailoring the chemotherapy, it's still hard because we really do not have reliable biomarkers. And most importantly, even if you want the patients to get some sort of a novel or an experimental chemotherapy, patients could lose significant weight and are malnourished. And that's why their performance status becomes really poor, and they may not be eligible for participating in usual clinical trials. And as I said, the pancreatic cancer is really resistant to standard chemotherapies because it's highly tumorigenic. Uh, so then what do we do? The option two, and which is unfortunately the most likely option for most of the patients, is palliative therapy. But this is where I want to emphasize, going to palliative therapy does not mean you are accepting defeat. Sometimes palliative therapy may be the right thing for you. You may develop a cancer, you may have a surgical resection, but you may develop all sorts of complications after the resection, and that could impact your quality of life, and you could still develop recurrence, and it may not be worth it. Rather, have palliative treatment right up front, and that would palliate all your symptoms. So these are all things, these are all discussions to have with your oncologist, with your multidisciplinary team. And palliative therapy is, again, as I said, it's not an end of life care. Uh, you kind of also have a big, as patients, you kind of decide how to tailor your palliative therapy, but the overarching treatment goals are to control the disease, to extend your life, and to ameliorate the symptoms, and most importantly, to maintain the quality of life. Um, and again, for palliative therapy, we typically use chemotherapy. Radiation is also used. But if patients have pain, we could do painkillers. With analgesics, we could also do, as advanced endoscopists, we come into play to do celiac plexus neurolysis and so on. Um, the one thing which often gets ignored is nutrition. And as gastroenterologist, nutrition is really very, very important. And I keep emphasizing that a lot of the patients develop what we call as exocrine pancreatic insufficiency. And we typically put these patients on the pancreatic enzymes. And a nutritional high protein diet and is really important. Oncologists may often prescribe some appetite stimulants as well. And then, you do need to keep an eye on for other things like diabetes and malnutrition, and you do want to. That's where the multidisciplinary team we have at the Masonic Cancer Center really comes into play. So, one question which patients typically ask me is, could we have seen this before? Could we have screened, and could we have avoided this altogether? Um, the pancreatic cancer, unfortunately, does not have really robust screening strategies. We are still very much at the infant stage as far as pancreas cancer screening strategies are concerned. The NIDDK has invested a lot of money in this. Um, this is not like colon cancer, this is not like lung cancer, but who are patients who are eligible for pancreas cancer screening? Typically, these are patients who harbor some sort of a genetic mutation which are notorious to cause pancreatic cancer. These include Peutz-Jeghers syndrome, genetic mutations like CDKN2A, BRCA1, BRCA2, all the Lynch syndrome genes, and PALB2. These are some genes which could cause pancreatic cancer in future. So these are patients who would benefit from pancreas cancer screening. If you have multiple first degree relatives with pancreas cancer, it's kind of debatable, but it may not be a bad idea to start thinking of pancreas cancer screening. And typically, the pancreas cancer screening involves doing an endoscopic ultrasound and an MRI every year. And we kind of alternate with EUS and MRI every year. Um, so again, we have to take pancreas cancer screening with a pinch of salt. There are arguments which favor screening because we have a big CAPS database, and that has produced several prospective studies which showed that if you identify pancreas cancer in high risk individuals early on, you could really change their outcome. The 3 year survival was like in patients who were getting pancreas cancer screening was like 85% as opposed to 25% who were not screened. So the benefit is obviously in those in whom the prevalence is the most. And the prevalence is the most in patients who harbor those genetic mutations we talked about. But it's also important to know the EUS and MRI are not foolproof, and so you really do not have robust screening strategies. And the typical argument against screening is you really have to screen a lot of patients just to identify a few cancer. And most importantly, the psychosocial aspect. If you patients freak out and are super anxious, and because they may have heard of their friends or relatives who have died of pancreas cancer, and you really don't have an incredibly sensitive test to allow for reasonable positive predictive value. But again, the NIDDK is working towards this, and we are trying to get better as far as pancreas cancer screening is concerned. So, so what is in your hands? How can you avoid pancreas cancer? I would say go cold turkey on cigarette smoking. Cigarette smoking is an absolute no. It's the most notorious risk factor for pancreas cancer. I would try to avoid processed food and try to be on a low fat diet. At least remember that visceral fat and obesity contributes to pancreas cancer. And if you should try taking all precautions when you are working with toxic metals and industrial chemicals. So again, my take home message is pancreas cancer is very difficult to diagnose. Awareness is important. Some of the cardinal symptoms are painless jaundice, unintentional weight loss, loss of appetite, new onset diabetes, and abdominal pain, stool changes like pale stools, itching. These are all some of the cardinal symptoms. High risk groups are those with those genetic mutations we talked briefly on. Patients with family history are at more risk. Patients with chronic pancreatitis are at more risk. Um, Imaging, blood test, and fine needle biopsy. This could include CT, MRI, endoscopic ultrasound, CA 99. These are your ways of diagnosing pancreas cancer. We talked a lot about management, including surgery, neoadjuvant chemotherapy, palliative chemotherapy, and radiation. Palliative care means fighting the cancer. It's not admitting defeat. Sometimes that's the best possible outcome. Sorry, sometimes that's the best possible management strategy. And research advances are being done towards early detection and identifying high risk individuals. The NPF has a wonderful animated pancreas patient resource. I have taken some several slides from that, and it has a lot of presentations and lot of details on pancreas cancer for patients, and it's a very useful resource. I would recommend uh, patients if they are seeking information to look at the NPF website, and University of Minnesota and the Masonic Cancer Center is an NPF site as well. We are one of the pancreas centers of excellence. Finally, it takes a village to manage pancreas cancer, and this is our village at University of Minnesota. These are the gastroenterologists here, myself, Dr. Sean Mallory, Dr. Stuart Amato, Dr. Nabil Azim, Dr. Dirwish, and Dr. Marty Freeman. We have really good APPs, Jess and Amanda. And these are the surgical oncologists led by Dr. Eric Jensen, David Brower, and Dr. Ankeny. And these are some of the medical oncologists led by Dr. Ed Greeno, Emil Lu, Arjun, and Ajay. And we have so many nurses and coordinators, some of whom may be in today's call, who really help us in managing pancreas cancer. Pancreas cancer is bad news, but we can make it better. And again, I would like to thank Masonic Cancer Center for this wonderful opportunity. Thank you.
Thank you so much, Dr. Guru, for that incredibly thorough and clear overview of pancreatic cancer and for helping us understand such a complex disease in a digestible and accessible way. So, we are now going to transition to the conversation portion of our fireside chat today. And so, submit any questions that you have. This is your time to engage with an expert in the field. And as folks are thinking, I'm going to get our fire started to set the mood and cozy and warm things up a little bit for our conversation. So we had quite a few questions submitted through the registration. So I think I'll start with those while folks think of questions to ask in the Q&A. So you talked a little bit about the onset of diabetes as a potential warning sign. When should somebody be concerned enough and to bring this up to their doctor? And is this something that doctors are already bringing up when older patients are being diagnosed with diabetes?
So, excellent question. So, if you become diabetic, that does not mean you have pancreas cancer. Let me just throw it out there. It's the combination of becoming diabetic, at that 50, 60-year age range, and losing weight at the same time. So the most common type of diabetes is type 2 diabetes, which is usually associated with weight gain. You develop weight gain, you have insulin resistance, and you become diabetic. That's the most common presentation of diabetes. But suddenly you lose weight and you become diabetic, and you are in that age group, and you have some family history, and you're a smoker. That's when it should start making you think, is there something else going on? But I don't want patients to freak out just because they were diagnosed with diabetes. The diabetes doesn't mean diagnosis of pancreas cancer. It's diabetes along with significant weight loss.
Okay, that's helpful. So there is a question that was just submitted. Are there any vitamins or supplements that can help reduce risk?
So antioxidants typically help, but does that mitigate your risk to zero? No, I think the most important things are things like what we talked about, avoiding cigarette smoking, avoiding processed red meat. Those are the things, avoiding exposure to toxic chemicals, industrial chemicals, toxic metals, or taking precautions. Those are your, I mean, those give you more bang for the buck. But antioxidants like can help, but they do not mitigate the risk completely.
Okay, thank you for that. So, is there any benefit to genetic testing if somebody's already been diagnosed with pancreatic nodules?
So I don't know if you're talking about pancreatic cyst or pancreatic. So pancreas cyst is an altogether a different beast. And again, I did not touch a lot about the pancreas cyst today because pancreatic cyst is incredibly common in the population, and uh, roughly 10 to 20% of pancreas. If you scan someone above 70 years, roughly 10 to 20% could have a small cyst. But cyst does not translate into cancer majority of the times. So if you start screening nearly 10% of 70 and above with genetic testing, that's a lot of genetic testing you'll be doing. So we do not recommend genetic testing for pancreas cyst. So the genetic testing really helps if you have pancreas cancer among other family members, two or more first degree relatives. If you have other associated pancreas cancer, like cancers which are associated with Lynch syndrome, like say colon cancer, endometrial cancer, breast cancer, that's when you need to start thinking of, do you have like some sort of a genetic mutation which is putting you at risk? So the like the Lynch syndrome or the Peutz-Jeghers syndrome.
Okay, so what does that surveillance look like then for someone who has that family history or the genetic mutation?
So typically, we do recommend these patients to have them tested by our genetic counselor, make sure that they really harbor those mutations. So then we have a pancreas cancer screening program at University of Minnesota, and we touched a little bit about it because we do it in this target high risk population. But typically, what we offer is an endoscopic ultrasound and a high quality MRI with IV contrast, and we kind of alternate every year. But as I said, it's not foolproof, it's not robust, but that's the best thing we have. So we recommend it to those high risk individuals.
Okay, so keep the questions coming. There are so many really good ones. So, what does the future offer as far as treatment advancements?
So, the advancements, we could talk about advancements from the gastroenterologist standpoint. The gastroenterologist standpoint, we are getting better and better diagnosing smaller and pancreas cancer. We are getting better processes for endoscopic ultrasound. We are having better needles. When I started after my fellowship, we were using a fine needle aspiration needle. Now we have fine needle biopsy needles, and we are able to give much better tissue. And that kind of translates because once you have good tissue, the oncologists are able to do very good next generation sequencing. Roughly 1 to 2% of patients can carry some actionable mutations, and they could get some precision treatment like platinum based therapies, but it's very uncommon. But still it's 1 to 2% who could who could benefit from next generation sequencing and chemotherapy tailored to their actionable genetic mutation. The chemotherapy regimens are getting much better, and then there is a lot of research going on. We talk about tumor stroma being difficult to penetrate. So then the oncologists are coming up with some stroma busters like hyaluronic acid based chemotherapy. There are, and then immunotherapy is coming into play of late. Not as much in pancreas cancer as like melanomas or lung cancer, but it's also beginning to find its feet here. Radiation, getting more sense, they're trying to target the pancreas cancer better. The surgeons are getting more and more, Whipple was typically done with laparotomy, but then now they can do it with laparoscopy, they can do it with robotic Whipples are also being done. So, we are making progress in every direction. because pancreas cancer is has dismal prognosis, but we are not there yet. It's not like breast cancer or colon cancer, but we are not there yet.
Are there any advancements that excite you that you're particularly interested in?
Some of the liquid-based biopsies and the next generation sequencing is exciting to me because that's something I could contribute. Some of the screening, in NIDDK, I'm part of the CPCRC consortium, and they have a detect study going on that's trying to target which patients are really the highest risk we should target for screening. So those are some research I'm looking forward to because if we kind of establish the high risk population and target them, maybe we'll get more bang for the buck.
Okay. All right. So if a patient has intermittent pancreatitis and has had abnormal liver enzymes along with stool changes, do you have any recommendations?
So, you know, that may not necessarily be pancreas cancer. What you're looking at could be, you're talking about recurrent acute pancreatitis. That could be from something benign like a stone, which is floating in the bile duct, or it could be from a stone in the pancreatic duct bed. That is more typically to cause recurrent enzyme elevation and cause pancreatitis as the stone is ball valving and irritating the pancreas more than pancreatic cancer. But that patient should definitely come and see us, and we could do a thorough evaluation and take care of this patient.
Okay. All right. So for somebody with IPMN, you'll have to tell us what that acronym is. How can you best monitor, and are there any proactive measures that they can take?
That's a wonderful question. So, IPMN is intraductal mucinous neoplasm. So, remember we talked about pancreas cysts. The IPMN is one of those cysts. It's one of the most common type of cysts. So, these IPMN, again, based on the cyst morphology, we can classify them into the really worrisome and high risk malignancy stigmata or high stigmata for malignancy and a low risk. So if a cyst is typically has mural nodules or cyst wall thickening or if the size is greater than 3 centimeter and is causing pancreatic ductal dilation along with some worrisome features like weight loss or jaundice, um, or if the cyst is growing suddenly bigger in size, like 10 to 20% growth in a year, those are all the cysts which I worry about could turn into cancer. But typically, a lot of these patients could have an IPMN or a side branch IPMN, and they could be really small. They are incidentally diagnosed, and we do MRI based surveillance. We may do endoscopic ultrasound if it warrants one, but we typically follow them with MRI based on the cyst size. And it could be anywhere between 6 months to 18 months based on the cyst size.
Okay. So what role does clinical trials play in treatment for pancreas cancer? Are there any clinical trials that have shown promise?
So that's a good question for the oncologist, because I do not primarily participate in pancreas cancer based clinical trials. But what role it could play, there are all obviously, if you have good functional status, you may be eligible to participate in some clinical trials. Um, you do not know if it's going to work or not, but it's better than not doing anything. So I would encourage patients, if they are eligible, to see if there is something. But remember, clinical trial, usually those are patients who failed the first line and of the chemotherapy, or they are having some disabling side effects. You're not going to be offered a clinical trial drug unless you fail or you're not eligible for the first line.
Okay, and I will just plug the Cancer Center's nurse line. So we do have a nurse line. It's a great resource for anyone who wants to learn more about clinical trials available at the University of Minnesota. I'll make sure that we include the number to speak to our amazing nurse, Patty. in the post follow-up email that will go out tomorrow. So I just wanted to make that plug. So before we close, I have just maybe like two more questions that I'll ask you. So sorry, everyone, that we are not able to get through all of the questions. So we talked about the impact that pancreatic cancer has and that it typically impacts the whole family. And so I'd love to kind of hear how the resources that you typically recommend for patients and families as they navigate this diagnosis, because how you outlined, you're typically the first one that is sharing the news with patients and their families.
So, when the patients come to me, they usually do not know they have pancreatic cancer. They usually come to me with a pancreatic mass. They are unlabeled. They do not have a diagnosis. So, my job is to establish the diagnosis by doing the endoscopic ultrasound, fine needle biopsy, stage the pancreas cancer, and then I kind of hand them over to the medical oncologist. The medical oncologist, and we have a stellar group at the University of Minnesota, and they are the quarterbacks, and they kind of hand over the care to the surgical oncologist if the patient is a surgically resectable patient, but they typically manage them along with the surgical oncologist, and we have an excellent palliative team as well, and those are excellent resources for a lot of these questions as far as pain is concerned, nutrition is concerned, physical therapy is concerned, and we also have social workers who could help. But the another thing which I feel is unique about the Masonic Cancer Center is the Hope Lodge we have. A lot of the
Mhm.
patients, if they have a pancreas cancer diagnosis, them and a family member are eligible for some accommodation through the Hope Lodge. But you have a really good social worker, a lot good team of social workers who could really help with as far as the transitioning the care. And we, as I said, we also have a good hospice team, and to make sure that the patients don't suffer a lot. So as I said, the Masonic Cancer Center is, I cannot be more proud of it.
Thank you for uplifting that. And it's, as you mentioned during the presentation, it's kind of the whole package is folks get when they come to the Cancer Center. So we are going to bring this discussion to a close, unfortunately. We are running out of time. But before we do that, just one final reflection from you, Dr. Guru. If our audience could walk away with one key message about pancreatic cancer today, what would you want that to be?
I would say stop smoking.
There we go. Okay. And we know smoking can lead to various cancers, so not just pancreatic cancer. So I think that's a really good key takeaway for folks to walk away with. So we are out of time and we're gonna have to wrap it up. But I want to express my sincere gratitude and appreciation for everyone who joined the conversation today. Thank you, Dr. Guru, for sharing your expertise and your insight and for helping us shed light on a disease as challenging as pancreatic cancer. But before we officially close, I have a few just quick things to share. So please take a moment to complete the brief survey that will auto-populate when we close the session out today. And then also it will be included in the follow-up email that will go out. We had a few questions about the recording. So the recording will be available on the Masonic Cancer Center's YouTube page. And all of this will be included as well in the follow-up email that will go out tomorrow. But please complete the survey. Your feedback is so essential. It not only helps us improve future fireside chat, but also will guide us in our planning for 2026. And so we want to bring you topics and speakers that matter most to you. And as a small token of appreciation for completing the survey, you can enter to win a drawing filled with goodies from the Masonic Cancer Center. If you're interested in keeping up with everything happening at the Masonic Cancer Center, make sure to follow us on social media or subscribe to our monthly newsletter for updates, resources, and event announcements from the Office of Community Outreach and Engagement. Thank you again, everyone, for being here and spending part of your day with us. Happy holidays, and we look forward to seeing you in 2026.